This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast.
Hello, Prostate Cancer Real Talk family. This is Shay, and I'm here with my husband, L. We thought that it would be appropriate to begin this episode with a brief discussion about the recent high-profile prostate cancer cases in the news.
Thank you, Shay. And these specific cases that we're referring to include Secretary of Defense Lloyd Austin announcing his diagnosis, and also the heartbreaking loss of Dr. Martin Luther King Jr.'s youngest son, Dexter King. He passed away in January of 2024. And we also lost Sirius XM host and civil rights activist Joe Madison. He also passed away in late January of 2024. So these high-profile cases serve as vivid reminders of the elevated incidence of prostate cancer, particularly among Black men. So, the question is, why is this disease so prevalent within the Black population? Is it genetics? Is it lifestyle? Is it geographic location? Or perhaps is it the bigger issue of healthcare inequity? Well, we're going to delve into this today with Dr. Adam B. Murphy of Northwestern Medicine here in Chicago, and he's going to enlighten us on the increased risks of developing prostate cancer among Black men and to help us explore what some of these possible causes are. So Dr. Murphy's going to get into that. And also, one of the key things that we do this podcast for is to encourage men to get their PSA test. And PSA test stands for prostate specific antigen. Dr. Murphy's going to explore that in detail with us to show you how necessary these PSA tests are concerned. My personal story is, I went for PSA tests regularly, and as a result of that, my prostate cancer was caught early and it was treated early, and all of my subsequent follow-up tests have been 100% cancer-free. So, just shows you the importance of early detection and treatment, and a key part of that is getting regular PSA tests, and starting for Black men around, early to mid-40s. Particularly if you have a family history of prostate cancer. So, Shay, we're going to join Dr. Murphy now in exploring this issue. Why are Black men affected more by prostate cancer?
Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And Black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors, a place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk. In this episode, we welcome back Dr. Adam Murphy. Dr. Murphy is a distinguished professor of health equity research in urology preventive medicine, cancer epidemiology, and prevention at Northwestern Medicine in Chicago. He has been studying the health disparities faced by minorities in prostate cancer, looking at the role of vitamin D deficiency, genomics, and biomarkers in disparities for men at risk of and already diagnosed with prostate cancer. Dr. Adam joins us today to further his community outreach and to continue his mission of education and prevention. Now let's welcome back for Season 2, Elle and Shay.
Prostate Cancer Real Talk. This is Elle, and I'm here with my wife, Shay. Hello, Shay. How are you today?
Hello, Elle.
So we're very fortunate to have Dr. Adam Murphy with us today. Dr. Adam, so why don't we start out by asking you to give us a little overview of what your specialty is and any comments that you'd like to make to our listeners as we discuss the topic of prostate cancer. And specifically today, we're going to be leaning toward the discussion of Black men and prostate cancer.
So first, Elle and Shay, thanks for having me. Dennis, thank you for that great introduction. I always sound better in other people's mouths than my own. It's really an honor for me to be able to be a part of something like this where you're doing community education on something I'm really passionate about. My father and grandfather are both prostate cancer survivors. And so I've seen the impact of this disease in the Black community. My godfather actually died of prostate cancer at the VA that I work at.
Oh.
So and I just think this is a great thing that you all are doing. I guess I would say, to kind of talk about what I do, is I'm 50% general urologist. So I treat patients. I am really an advocate for patients making informed decisions. And that's why I'm really about health literacy and kind of public education. And then I'm also 50% researcher. I have a lab at the Jesse Brown VA and at Northwestern University focused on basically the reasons why African-American men have prostate cancer more often and more aggressively. And more recently, I'm focused on precision oncology and making sure that these great tools and tests that we use in prostate cancer to diagnose or, predict kind of outcomes, make sure that they work and make sure that they're usable and affordable and insurance covered for African Americans.
So, along those lines, why do Black men? I know this is what you're trying to solve. You don't know the answer, but give us some insight in terms of why Black men are so prone to this disease.
It's an interesting question you ask. It's very loaded because there's, there are twin studies that they do to kind of see how much of this is genetic, right? And somewhere between 33 and 45% of it seems to be genetic. So family history is the biggest, one of the biggest risk factors besides age and Black race. And so when I first got into this, I thought the Black Race Association was really due to our West African ancestry in that it was a genetic defect and somehow. And I'm not sure that that's true anymore. We got to do an autopsy study in Nigeria, actually, and we found that the rates of prostate cancer in Nigerians, our motherland, for at least 70% of Black Americans, they have much lower rates of prostate cancer than even white Americans. So right now, my thought is that it's, social determinants of health, and it's kind of what we call gene-environment interactions, where the genetics that we had in West Africa made it so that our rates of prostate cancer were pretty low. But when you expose that genetics to the American environment, and that also applies to the United Kingdom and Europe, something about what we do differently in that environment increases our risk. And for that can be lots of things. It can be the diet. It can be vitamin D deficiency, like I study, and sun exposure. It could be stress. It could be systemic racism. It could be lots of things about how we access healthcare system. So it's a mixture of things. It's not like, cigarette smoking leads to, lung cancer or HPV leads to cervical cancer. It's a lot of causes, and that's the reason why it's so complicated.
I see. As we're talking to our listeners about this disease, what are some of the things that a man, any man, Black or white or any man at all, what are some of the things that we can do to perhaps prevent it? And then I'd like for you to also include in your response to this question, talk about testing and the role that early diagnosis plays in this.
Elle, I didn't pay you to say that, but that's exactly where I was going to go.
Okay. I read minds too. I forgot to say
It's like you've done this before.
I have.
No. So what can we do for prevention? I mean, the number one, I think that I want people to realize that they should be screened. Because of the controversies in PSA screening for the population in general, I think it's dissuaded or persuaded a lot of primary care doctors to not screen for prostate cancer. But I think that message really hasn't applied very well to African Americans, because it's done a disservice, because as you said earlier, there's 50 as high as 70% higher risk of prostate cancer in our community. So the benefits of screening are higher for Blacks than the general population. So right now, screening gets the letter C, a grade of C, from the U.S. government for screening, meaning it's up to the patient and the physician to have a conversation to talk about that. That the benefit of screening is probably a lot higher in a group that's had it more often and more lethally, right? And so for African Americans, the American Urological Association, which is, who gives us our guidance as urologists, they say starting at age 55, and kind of say the decision should be earlier for African Americans, but it's a discussion, right? Mm-hmm. So what we tell people now is starting at age 40, you should get a baseline PSA. And then if it's above the median for your age, which is 0.7, you should be getting screened at some interval every other year, perhaps, from 40 to 55, to make sure that you're not one of those people who progresses to a significant cancer. If you're below median, you don't have to probably screen again until at least age 50, maybe even 55. So if you catch the people who are above the median level at 40, you capture 90% of the people who would ever die of prostate cancer. So there's a lot of data behind that strategy.
Okay. So one of the terms that you just used was PSA. So those of us on the call, we know what that is. But to the listeners, what is a PSA? What is that?
Thank you for asking that, because people call it a PSI per square inch because they're used to filling their tires. And that measure means something to them. PSA is prostate specific antigen. I got to work with a guy who is kind of the father of the PSA test, Dr. William Catalona at Northwestern now. And it's still the preferred screening test to see when people should get biopsy. And in general now, people are saying if the level's above 4, you should get a biopsy. The main way we detect prostate cancer, but it's not the easiest of measurements to work with, because there can be people who are missed who have a PSA less than 4 that still have, significant cancer. But in general, that's what we use. And the reason why we talk about using it every other year is because sometimes changes in the PSA, especially big jumps, are signals of cancer too. Mm-hmm. So, anyway, PSA is a test.
That's what happened to me, actually. And so to be clear, the way that they gather the PSA, it is a blood test. It's not a urine test. So your urologist will actually draw blood from you, and that's how they run that test. And I know that some men are reluctant to get tested for prostate cancer because they're still thinking about the old finger test, if you know what I mean. But the PSA is more precise than the finger, correct?
So the PSA test should be done by the primary care doctor too, not just a urologist. We confirm it. That's one. Two, the PSA does detect about 80% of the prostate cancers by itself, but you can detect another 15% with the rectal exam. So it is an important part of the screening exam that should still be done at least every other year. Okay. Now, people who don't want to have the PSA, who don't want to have the rectal exam, it's definitely better to do the PSA than not do either test.
Okay, so Dr. Adam, you said that 50% of what you do is research. So I'm wondering if you could answer this. Now, in L's case, he had that spike sort of like all at once. Like his PSA was normal. It was just always normal. And then all of a sudden there was a spike. I don't know if you know the answer, but that just blew my mind. Like all of a sudden he came home and said, there's a little concern. My PSA level has elevated. It was like out of the blue. And I was like, okay, well, what does that mean? And he's like, well, the doctor want me to have further testing. They kind of want to monitor it, and they want me to come back again in 3 months. And when he went back, it was even higher. And then that's when he had to have the biopsy, then, of course, with the diagnosis of having prostate cancer. So that was really shocking for me that it just kind of spiked like out of nowhere.
Yeah, we're lucky in that that's kind of what happens for a lot of people. And I know with your story, they're all individual stories, so I don't want to conflate them. But when you see tumor cells, what tends to happen is that you go from this like really kind of normal cell, prostate cell, and then it accumulates these mutations, genetic damage to their cells. And sometimes it's not actually mutation, sometimes it's suppression to what's called epigenetics, where your diet, your sun exposure, your stress, all that can do changes to the DNA, but not actually make a mutation, okay? It can suppress the expression of abnormal growth, right? It suppresses abnormal growth or tumor suppressor genes. But anyway, the point is that at some point it accumulates enough changes where it starts to act like a cancer. The normal checks and balances that the cell had to prevent it from actually going out of control, and your cells have a lot of those checks and balances. At some point you accumulate enough damage where those checks and balances are no longer working, and all of a sudden this tumor that was kind of low growing and small and being kind of kept in check by your own body is now evading the immune system, or is now recruiting blood vessels to come to it. And that's what brings the PSA levels up. It leaks more PSA into the bloodstream because of the extra blood vessels.
Okay, so are all prostates created equally? Meaning
the constitution of prostate.
Seriously, like, so
they're not all created equal.
Okay, I didn't think they were. Okay.
The reason why I say that is that some people are already born with mutations in certain genes that are tumor suppressors, right? And they need less damage to happen for them to become a cancer. And then the rate at which we accumulate damage to our DNA or our epigenetics also depends on what we're eating and how we're stressed, right? If we're around cigarette smokers or we're alcoholics at some point. So maybe at birth they were similarly equal, but again, there's hereditary prostate cancer. So we know for a fact that they're not all created equal.
Okay.
And to that point, I had a conversation with a gentleman who is also a prostate cancer survivor. As a matter of fact, he's going to be on the show with us at a later date. But he said his PSA level went from 2.5 to 5.5 in 8 months. And then in the next three months, it went from 5.5 to 7.0. So, is that an indication of an aggressive prostate condition? What do those numbers say? How do numbers quantify the risk of prostate cancer?
So there's two different concepts that both predict kind of either mortality from prostate cancer or recurrence after you've gotten treated for prostate cancer. And it's called the PSA doubling time. So the faster the PSA doubles, goes from 2.5 to 5 to 10, is predictive. So if it's less than 2 years, that's a risky doubling time. if your PSA velocity should go up about 0.35 to 0.70 per year, and if it goes up more than one a year, that's a risky number. So yes, you're right. The PSA changes are a proxy for the tumor growth, the growth rate of the tumor.
And I know I'm asking a lot of questions. I guess that's why we're here. But, when you're talking about prostate cancer and whatnot, and particularly for Black men, it brings to mind the vaccine that we're talking about with COVID. Some people, are reluctant to take the vaccine because of one thing or another. And I always say, what are you afraid of? You think you're going to wake up with goat horns or something in the morning? What do you think is going to happen that's so terrible? So when you talk about prostate cancer, I don't know why men, in particular Black men, would avoid going to their doctor and getting tested regularly for prostate cancer, particularly, like you said, when you're around 40, just go and have it done. So one of the things that we want to do with the show here is to really encourage people, and I'll use the word encourage because I like to say something stronger, but get your behind to the doctor and get tested. Talk about testing, prevention, and how critically important that is and what difference it makes for mortality rates.
I think you asked a great question, and I think you are on the one end of the curve, bell curve of people in seeking health promotion. You talked to me about that you've been going to Northwestern for years. And, I have a lot of patients who don't have as much trust in the healthcare system that you do. And this is probably why you're doing this show, because you see the benefits of it. But a lot of my patients say that every time they go to the doctor, they get bad news, right? And that we are bad news deliverers or drug pushers, and a good way to avoid stress is to not know there is a problem. Of course, it's a dangerous solution, right? There is a danger to putting your head in the sand. But when we get overwhelmed with too many negative pieces of news, we can't handle it all. And I think that you see that with the whole COVID response, right? People wanting to deny the need to wear masks, people denying the reality, thinking it's a government hoax, is because we don't want to deal with stress all the time. We want to live our normal lives. And I think this is just another example of it's too much. It isn't healthy, but I think it's too much for some people. Mm-hmm. But I think you're right. The right answer is go in and be proactive. I used to give them the message of when I turned 31, which is several years ago now, I wanted to go to the doctor every year because I was a physician who did not have a primary care doctor, right? And I was a busy resident and I had a family already and was like, I don't have time to go to the doctor. I'm healthy, I feel great. But then I started to realize, I could have high blood pressure or high cholesterol. And it would be years before I would actually realize, that I was doing damage to my arteries, my heart. Maybe I was going to be a pre-diabetic, you gain 2 pounds every year and all of a sudden you creep into diabetes space, right? And I just wanted to know ahead of time so that I could be managing these problems as I go. But it's a very, very kind of health promoting decision. That's not most people don't make that decision.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, ellandshay@prostatecancerrealtalk.com. That's LEL and Shay, SHAY, @prostatecancerrealtalk.com.